Very good evening to one and all. I am Dr. Ravin Verma, Managing Director, Wehealthify. Hope you're all safe and healthy. The primary intention regarding this COVID awareness program is to clarify on the basic facts that are related to COVID and to provide interaction with expert physicians. The topic for today's evening is childcare in the pandemic. I now invite Dr. Satish Kumar Garu, who is a consultant neonatologist at Krishna Hospital, Visakhapatnam. I request him to share his ideas, experiences, and express his views in all the aspects that are related to current COVID situation among neonates and children. Thank you.
Good evening, everyone. Today, I'd like to talk about the child care in pandemic. But platform itself is a unique platform where doctors and the patients and attendants are participating in the same platform. So it's a little bit exciting. So today the topic I told you, the child care in pandemic. So first of all, we should know how the COVID virus looks. See, it's as simple as this, like it consists of the covering layer, which consists of spike glycoprotein, the membrane, and envelope protein. Inside that, you'll find the mRNA. In that mRNA, the main important is the mRNA component coding for the spike protein, which is important. Then you can see the spike protein getting attached to the ACE receptors, the host epithelial cell receptors. Then the main important is, as we know, the COVID infection spread from person to person and also by air, not only by these modes, but also by the objects, the surfaces like lift buttons, laptops, digital devices, doorknobs, tissues. And so if you touch something contaminated and then touch your face or another face, you may all fall ill. So be careful. The coronavirus, which is looks like a crown, it will get attached to the ACE receptor present over the respiratory tract, especially in the nose, the throat, and in the GI tract. So you can see the receptors here, and you can see the virus. Once it gets attached to that one, then it will enter into the cell where the RNA will be separated from this covering, and where the RNA will be decoded, and the RNA replication will happen. And along with that, the spike protein, the envelope, will be manufactured in a rough endoplasmic reticulum and also in the Golgi apparatus. Finally, the virus will be formed and it will be pushed out, or it will be come out by process called exocytosis. Then whatever the virus releases from the cell, it will infect the neighboring cells. That's how the infection spreads, and it spoils the lung or the tissues which have the high ACE inhibitor receptors. And coming to the symptoms wise, the symptoms are much less in the children compared to the adults, such as the fever, cough, headache, sore throat, myalgia, shortness of breath. So we may feel that the symptoms are less. The kids may not get affected, but kids will be affected. But symptomatically wise, they are less. So other people have the doubt that is it a COVID infection or a flu or it's the allergies. See, the unique features will be the common symptoms and unique features of COVID-19 will be they have the fever, dry cough, shortness of breath, difficulty breathing, fatigue, chills, and headache. And other features will be new loss of taste and smell, a repeated shaking with chills, and sore throat, running or stuffy nose, and body aches. The incubation period for both COVID-19 and flu infection will be same. That is, for COVID, it is 1 to 14, and for flu, it is 1 to 4 days. So in case of flu infection, they will have the fever, cough, sore throat, fatigue, body aches, headache, and loss of appetite. They have the runny or stuffy nose. The allergies, that is quite different. They don't have any sort of incubation period. When the person or the child will come in contact with the allergens, they will have the sneezing, congestion, running or stuffy nose, itching, and watery eyes. So allergy symptoms typically affect parts of the head and are not accompanied by. This is now about the perinatal and neonatal update. Yeah. So in the first, we have to know how it gets transmitted from the mother to the baby. So first one is the theory of intrauterine transmission, the real of intrapartum transmission, and the most common of immediate postpartum transmission. So in the intrauterine means when the baby is in the mother's womb, the baby may get the infection. There is a chance, it's very, 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 very mere, or can say it is very remote. The hematogen is spread through the placenta or viral particles in the amniotic fluid, the inhalation or ingestion of the particles by the fetus. It is a very, very, very rare, and it is approximately around 1% of people. And the intrapartum is, that is during the time of delivery, that is exposure to the infected maternal blood, that is exposure to infected secretions, and exposure to infected feces. So these are the most common modes of transmission during the delivery. And immediately after delivery is transmission from the mother, family members, or other healthcare workers, including doctors, staff, or whoever may be. The transmission from the breast milk is very, very, very negligible or less. So once we know the delivery, we know how the baby gets the infection, we should prepare ourselves for the delivery. So the job, our responsibility will start by the time of delivery. So it may be a normal delivery or C-section. We have to prepare ourselves that we should have a separate when it's possible. If not, we should have a curtain or physical barrier with a distance of 6 feet or 2 meters away from the birthplace. Then we should maintain, if possible, a closed incubator, and the person who is going to do the minimal number of people should be there for the resuscitation. The person who is going to do the resuscitation should be well trained. You should not waste the time there. So the resuscitation guidelines are on par with the routine resuscitation guidelines, but airborne aerosol spread should be avoided or should be contained. So instead of doing the while doing the bag and mask ventilation, you should use the two-hand technique rather than the one-hand technique. The other person has to do the bag and mask, and come down or do the minimal suctioning as if required. If not, don't do unnecessary routine suctioning, which will cause the release of the virus into the surrounding area. So the other person who is for the emergency, he will stay outside, so to avoid the unnecessary infection. And why the mothers are pregnant women are more at stake of morbidity or mortality, because of the physiological changes in the pregnancy and risk of thromboembolism. Usually they have respiratory compromise due to upward lift of the diaphragm and decreased lung capacity, increased heart rate and oxygen consumption. These are all leads to the respiratory compromise, and moreover reduces cell-mediated immunity. All these things will land up the mother or the pregnant woman to have the more ICU admission, invasive ventilation, ECMO, or mortality compared to the non-pregnant woman. So for the pregnant woman, the risk of getting the infection and the morbidity and mortality is high compared to the non-pregnant woman. The risk will become further higher when the age is between 35 to 44 years, and if they require any invasive ventilation, especially African American or the Asian people, they are much more prone for complications. So once they get the infection, they will be divided into two types. One is the early onset neonatal COVID infection and the late onset neonatal COVID infection. The early onset neonatal infection means usually they present between the 2nd day to 7th day after birth. Often most of the babies are asymptomatic and usually diagnosed when the mother or any family member has a COVID RT-PCR positive. When you get it done for the babies also, they may also get the positive. Otherwise, most of the babies are asymptomatic. And if they present with the symptoms, usually they present with a low-grade fever and loss of interest to take the feeds. That is what you call as refusal of feeds, nasal congestion or nasal flaring, irregular breathing. Sometimes the babies may have the GIT symptoms also, like diarrhea, and babies will be lethargic, and there will be bluish discoloration of the peripheries. And in case of late onset neonatal COVID infection, usually once they get discharged, they will be readmitted between 5 to 13 days after birth. And for them also, they have the low-grade fever or temperature instability. They will be lethargic, maybe means dull. They will have the breathing difficulty or apnea. Apnea means stopping of breathing in between. That is called apnea. And they will have a feeding difficulties, or they will not tolerate the milk. When you have a picture like this, if you take an X-ray of this, then you will have a non-specific opacities on the chest X-ray. When you go for the blood test, you will find the leukocytosis, lymphopenia, and thrombocytopenia. The other entity, what we know it as a MIS-C, it is also present in the neonate, what we call it as MIS-N. So multi-system inflammatory syndrome in newborns. It happens because of neonatal hyperimmune response, because it happens because of antibodies transmitted from the mother who got infected from the COVID infection in their pregnancy. So usually it affects the multi-organ. So that is called multi-inflammation. The group of symptoms related to the different organs. So it is a syndrome. So usually it affects the heart, which presents as a myocardial dysfunction, and it can be detected by the increase in brain natriuretic peptide levels and increase in troponin levels. When you go for the echo, you will find the coronary artery aneurysms or dilatations, and sometimes you may find the low LV function. And coming to the blood wise, they may have the signs, features of decreased fibrogen, increase the D dimers, thrombocytopenia, means low platelets, and neutropenia and lymphopenia, low white blood cell count. And because of it also affects the lungs, they may have present with the hypoxemia, means low oxygen saturation, and the feature suggestive of PPHN, pulmonary hypertension, and feeding intolerance and necrotizing enterocolitis, like picture, means that is infection to the GIT, means intestine. So they land up with the these such a features, and sometimes they also have the features related to the kidney, such as decrease in urine output, what we call it as oliguria, renal failure, and generalized body edema or generalized body swelling, what we call it as anasarca. The treatment for such thing is IVIG. I'm going to discuss further in next coming slides. So whatever may be the sort of infection, or maybe early or late, we have to continue the breastfeeding. It is the evidence is given by the WHO, World Health Organization. It concludes that based on the available evidence, WHO recommendations on initiation and continued breastfeeding of infants and young children also applied to the mother with suspected or COVID infections. So the breastfeeding, the COVID-19 does not transmit through. So WHO recommends breastfeeding for all mothers irrespective of their COVID-19 status, and COVID-19 suspected or confirmed mothers should practice the following to the prevention of transmission of infection to the infants, especially while breastfeeding. Wash hands before touching the babies, wear a mask, disinfect or clean frequently touched surfaces. So when to discharge the babies? The infant born to the mothers with COVID-19 should be tested COVID-19 infection, and as soon as the detection of COVID-19 contact with the COVID-19 positive person. Repeat testing may be needed if the baby develops symptoms within 14 days of contact or after delivery. So for the stable babies, tested negative for COVID-19 can be discharged based on the center's criteria with mother or caretaker. Asymptomatic newborn tested positive for COVID-19 may also be discharged with the mother or caretaker. If the mother is unwell, suppose if the mother is unwell, with appropriate precautions and plan for frequent visits and follow till 14 days after birth. Specific guidance regarding use of masks, gloves, and hand hygiene should be taught to all caretakers. So in mild to moderate respiratory illness, they can be discharged as soon as well for 3 days without waiting for any report. With the serial illness, it is prudent to wait for a single negative COVID test and resolution of signs and symptoms prior to the discharge. The next topic is the management of COVID-19 in children. Usually, they will be categorized into 3 types. One is the mild, that is minimal symptoms, the moderate one, and severe symptoms are the sick cases. The majority of children with the COVID infection may be asymptomatic or mildly symptomatic. They will have the features like, as I discussed in the bar diagram, the fever, cough, breathlessness, shortness of breath, fatigue, myalgia, rhinorrhea, that is throat pain or loose motions, loss of smell or loss of taste, like etc. A few children may present only with diarrhea or stomach pain or atypical symptoms. Then in new syndrome, what you call it as multi-system inflammatory syndrome, it has been detected and diagnosed even in the children also, which have the unique features of unremitting fever more than 38 degrees. Epidemiological linkage means the history of contact or history of COVID infection will be there. And clinical features suggestive of multi-system inflammatory syndrome, which I am going to discuss in detail in the next slides. So in asymptomatic and mild infections, child may present with throat pain or running nose or without any breathing difficulty and with fever, a mild fever. The few children may have the diarrhea or vomitings like features. They know the babies doesn't or children doesn't need any sort of investigation. These they can be managed at home and with the home isolation or symptomatic treatment. The children with underlying comorbidities, including heart failure, lung problems, or chronic organ problems, means kidney diseases, and obesity or excessive weight, can be managed if they have the minimum symptoms at the home itself. So, what sort of treatment they require? Remember always the paracetamol, that is a dose of 10 to 15 milligrams per kg per dose, may require once in 4 to 6 hours. For cough, throat soothing agents like warm saline gargles in older and adolescent. The fluids and feeds means you have to maintain adequate oral feeds to maintain the hydration and nutrition diet. Antibiotics not required. Antibiotics are useless. Remember. So for the patient attendance, for the other people, remember, don't ask the doctors for the antibiotics unless otherwise they prescribe. For the mild cases, the treatment in the home itself, what I suggested, and the other treatment like hydroxyquinone, favipiravir, ivermectin, convalescent plasma, tocilizumab, dexamethasone, all are not useful. There is no role in case of mild cases. Remember. So what you have to do as a mother or the parents, maintain and monitor the chart, including the respiratory rate, means how many times the baby is taking the breathing in 1 minute, at least twice or thrice a day, and look for any breathing problem for the baby. Is there any color difference or change in the hands and legs for the baby? Are the hands and legs are cold compared to the total body? And is there any decrease or reduce in the urine output? And check for the oxygen saturation with the pulse oximeter. How is the saturation? And maintain the fluid intake and look at the baby child's activity. Means the child is dull or active, make a note of it. If the child is dull or the above features are there, take the help of the doctors. Don't treat yourself or don't take the advice from the others. And the moderate case means in the first symptoms, if they have only sore throat, fever, and or with the stomach. If the child has a breathing problem, what I told you twice a day, if the breathing problem means if the respiratory rate is more than 60 for the babies who are less than 2 months, or respiratory rate more than 50 for the between 2 to 12 months, and respiratory rate more than 40 for 1 to 5 years, and respiratory rate more than 30 for more than 5 years. And if the oxygen saturation should be maintained above 90, then they are categorized as a moderate cases. Child may be suffering with mild pneumonia and may not be clinically apparent. So the investigation, no lab tests are required routinely unless indicated by associated comorbid conditions. The treatment should be admitted in a COVID health center or secondary health center and with the good facilities. Maintain the fluid and electrolyte balance. Encourage oral feeds, that is breastfeeds for infants. If oral intake is very poor, intravenous fluid therapy should be initiated. The child should be administered for fever. That is, main treatment is the paracetamol, as we are all aware of. And antibiotic like amoxicillin can be administered if there is any evidence of or suspicion of bacterial infection. For SpO2 below 94%, oxygen supplementation is advised. Corticosteroids may be administered in rapidly progressive disease conditions, not required in all children with moderate illness, especially during the first few days of illness. Supportive care is very important. In case of severe infection, that is, if the child has the breathing problem and the saturations are less than 90%, they are categorized as a severe COVID infection. They have the severe pneumonia or ARDS, acute respiratory distress syndrome, septic shock, or it may involve the other organs like heart, kidney, lungs. Apart from the lungs, it will affect all the organs. So such children may have the clinical features of grunting or severe retractions, lethargy, somnolence, or seizures. Such children should be admitted in dedicated COVID hospital, that is preferably secondary or tertiary healthcare center. The few children may require the ICU admission or HDU, high dependency care, and should be assessed for the thrombosis or HLH, hemophagocytic lymphohistiocytosis, and organ failure like symptoms. The investigation should comprise of complete blood counts, liver and renal function test, and chest X-ray. The treatment for this is mainly the maintaining the hydration by intravenous fluid. And if required, we can start with, depending upon the case progressiveness, we have to start with the steroids. That is, two steroids are available with us. That is the dexamethasone or methylprednisolone. The dose for the dexamethasone is 0.15 milligrams per kg per dose, max 6 milligrams twice a day. Equivalent dose of methylprednisolone may be used for 5 to 14 days, depending upon the clinical assessment. Antiviral agents, there is remdesivir, to be used in a restricted manner within 3 days of the onset of symptoms after assessing the child's renal and the liver function, which are in the normal range. The doses for this, more than if the child weight is more than 40 kgs, 200 milligrams on day 1, then 100 milligrams once a day for 4 days. Between the weight between 3.5 to 4 kgs, 5 milligrams per kg on the first day 1 and 2.5 milligrams per kg once a day for 4 days. There is no role of hydrocortisone and favipiravir, ivermectin, or any other drugs. So if the child develops septic shock, if it's getting further complicated or complicated cases comes to for the admission, with the septic shock or myocardial dysfunction, then he or she should require the bolus therapy to 10 to 20 ml per kg, and be cautious if the cardiac dysfunction is there. If any shock is shock, you have to treat like a shock. So early inotropic support with monitoring of fluid overload like other cause of shock should be handled. The children may need organ support in case of organ dysfunction like renal replacement therapy. And the management, if the lungs are involved, is having severe disease as acute respiratory distress syndrome, we categorize that one into mild, moderate, and severe. In mild cases, high flow nasal oxygenation or non-invasive ventilation may be required. In severe cases, mechanical ventilation may be given with low tidal volumes. Remember, the tidal volume should be between 5 to 6 ml per kg, and adequate lungs should be opened, and you can increase the handle on the rate. If the child does not improve clinically, even then may consider a high frequency oscillation ventilation, or some for young children who can tolerate the prone position, they can be handled in a prone position. The other entity, what you call as MISI, of late you could see in the newspapers, TVs, and everywhere, the third wave is going to hit the children very badly. Whatever maybe it may be virus or it may be MISI, the multi-system inflammatory syndrome. How we can diagnose this? It is mainly predominantly will be there between 0 to 19 years of age with fevers. With fever, more are equal to 3 days, and 2 of these features should be there: rash or bilateral non-pleural conjunctivitis, or mucocutaneous inflammation, signs, hypotension, or shock. Remember, for the mothers and the caregivers, if the child is having the fever after getting the COVID infection or in the contact with any COVID infected member in the family, if they're having a rash over the body, means ఎర్రగా దద్దుర్లు ఉన్నట్టు కానీ, కళ్ళు పుసులు కడుతున్నట్టు కానీ, నోరు అవన్నీ ఎర్రగా అయిపోతున్నప్పుడు కానీ, పెదాలు ఎర్రగా ఉన్నప్పుడు కానీ, లేదు బేబీ అంత చల్లగా అవుతున్నా కానీ, వెంటనే డాక్టర్ గారి సహాయం తీసుకోవాల్సి వస్తుంది. సో రిమెంబర్ దిస్ పాయింట్ ఆల్వేస్. And in the investigation wise, evidence of coagulopathy, there is PT, APTT levels, elevated D dimers, and off late, all the attendants, all the patients are aware of the COVID panel, what you call as routine COVID panel. So everyone knows what will be elevated and what sort of tests will be done. So be careful in what you call as going for the test and interpreting the test. The acute gastrointestinal problems like diarrhea, vomiting, and abdominal pain may be present. The other inflammatory markers like elevated ESR, C-reactive protein, and procalcitonin should be done and should be interpreted to rule out other sort of infections because of bacterial sepsis, because of staphylococcal or streptococcal shock syndrome. So evidence of COVID-19 infection in the form of RT-PCR or antigen test or serology positive should be done. Or we should get a history of contact with the patient with the COVID-19. So investigation, as I told you, and criteria should be enough to rule out and to diagnose as a MISI. So what are the drugs and what sort of drugs we have to use and how much dose? if the cardiac dysfunction is there, shock or coronary involvement, multi-organ dysfunction, then you have to start with the steroids, preferably the methylprednisolone, 1 to 2 milligrams per kg per day, intravenous immunoglobulins 2 grams per kg over 24 to 48 hours, and antimicro pills. And such kids should be admitted in the ICU only. If the child does not improve in spite of the above treatment, they should get the repeat IVIG, and the corticosteroid methylprednisolone dose should be increased up to 10 to 30 milligrams per kg per day for 3 to 5 days. And if there is any hot environment or coronary involvement is there, then you have to start with the aspirin and low molecular heparin with 1 milligram per kg twice a day subcutaneously, and you have to monitor the clotting factors. Steroids has to be stopped once they get control. Steroid has to be stopped over 2 to 3 weeks while monitoring the inflammatory markers. For children with cardiac involvement, repeat ECG after 48 hours and repeat echo at 7 to 14 days and between 4 to 6 weeks, and after 1 week if initial echo was abnormal. Remember, this is the flow diagram in the nutshell. So coming to the prevention aspect, cover your cough. That is one of the main important. So when you get symptoms of the COVID, always wear the mask so that you will not dissipate or spread the infection to the other people, even in our family members. So, and when you get the cough or sneezing, cover your face with the kerchief or tissue paper. Then if you don't find anything, then you can cough in a flexed elbow and wash your hands thoroughly. Help and protect yourself and others from the COVID-19 infection. Stay 6 feet apart from the person, at least 2 arm length from other person, and wear a mask and protect yourself from other people. These are CDC guidelines, Center for Disease Control Guidelines. So that's how you have to behave in the society with the other family members. Then other strategies for prevention of infection is the vaccination. That is the only solution at present with us to fight with the COVID infection. For the mothers, there is a debate till now whether they can get the vaccine or not in first trimester, second trimester, and third trimester. But definitely for the breastfeeding mothers, they can have the vaccination. So what sort of vaccinations are available in the world? Means we have a preferably one is the Covaxin, Indian made, and what you call as Covishield. The Covaxin is prepared by the whole virion inactivated. That is, the whole virion is inactivated. So that is a prepared, developed by the Bharat Biotech. The other one is the Covaxin in association with the AstraZeneca, Oxford University. They have developed the Covishield one. There they have taken the chimpanzee adenovirus and they have modified the replication deficit to enable the cause the human disease, and they have taken the spike protein as antigen. They developed the vaccine. The other one is the Sputnik. What you of late you can see in the newspaper is the Sputnik. It has a 2 adenovirus are been taken as a vectors for preparing the vaccine. In the first dose, they have to take the adenovirus of 26, and the second dose it will be adenovirus of 5. So remember, if you take the same, the first dose is different and second dose will be different for a Sputnik. For the Pfizer, which is like predominantly in the Western world, in the America and other countries, they have taken the spike nucleoprotein, the mRNA, which produces the spike protein, and they have with the surrounded by the lipid nanoparticle, and that will be injected into the body. And the other in the research wise is that they have taken the spike protein and they have added the adjuvant, and they are going to get the immunity. This is the in the research module at present. So these are the vaccines available. Whatever may be, once it is injected into the body, it gives the it is identified by our immunity, and it will be remembered in our immune system. And once they get infection, that will be useful to fight against the COVID-19 virus. So ultimate solution for the COVID-19 is only vaccination. Remember. So in spite of vaccination, there is still a lot of people are dying, but it gives a protection. But sometimes even after vaccination also, there is a chance of getting infection is present. What is right about the vaccination? I'm going to talk. The vaccination now another way work, stay safe at the work, and it is another way to help protect your and your family members, and it forms another layer for the protection. And why is COVID vaccine is important? It reduces the risk for infection, and if they get infection also, serious illness will be reduced. reducing the hospitalization and death if they have the vaccination. So it gives a lot of protection. Once you have the vaccine, you have to wait for at least 30 minutes after the vaccination and do take the second dose at the due date for the complete protection. And after the vaccination also, you have to follow the 5 important steps. Use mask correctly, wash your hands, and maintain the social distance. If you have any symptoms, isolate yourself. So can I take the COVID, can I get the COVID infection from the COVID vaccine? These are some of the questions which regularly we come across with the patients. No, never ever you are going to get the COVID infection from the COVID vaccine. Is it necessary for the COVID-19 recovered person to take the vaccine? Yes, it is absolutely. It is advisable to receive complete schedule for COVID-19 irrespective of past history of infection with the COVID-19. It increases your immunity power against the infection. But you have to wait at least 4 to 8 weeks. Of late, the government of India suggesting for 3 months after recovering from the COVID infection. Then how many days will the vaccine create an adequate immunity? At least after 2 to 3 weeks of completing the second dose, you will get the complete immunity. But next question will be how long the immunity will be there for the people who had the complete dose of vaccine, but it is not yet determined. Hence, the continuing use of the mask, hand washing, physical distancing are advised. Then, virus will COVID-19 will change my DNA? Never ever. So your DNA will not be changed. Don't get worried or don't get apprehensive about the changing of DNA complications of the vaccine. They're going to have the serious side effects of this vaccination. No, they only will have the mild one like tiredness, headache, pain at the site of injection, muscle pains or joint pains, which are can be handled by the simple. The people are having no vaccine is developed so fast. Is it safe or not? See, always no vaccines will go more testing than other other pharmacy items like tablets or injections. So it is very safe. The timeline was sped up, but never cut the corners of safety. So the speed was increased, but never compromised in the quality. So how the people have, how could they develop the vaccine so fast? Already helpful information. A lot of people participated in the clinical trials compared to the vaccines which are developed prior to the infection for the different vaccine preventable diseases. And government has invested a lot of money and manufactured has simultaneously manufactured the vaccines while they are in trials. So they are safe. So what is the efficacy of vaccine used in the trials? So all the global agencies have the set for benchmark that the vaccine should have at least efficacy of 50 to 60%, but we are lucky to have a efficacy of 70 to 90%, all COVID vaccines which are available all over the world. So the other question is, can I take the medication while having the vaccine? Yes, definitely, but try to tell to the vaccine giving people or the doctor who we are regularly meet. Is the vaccine contraindicated in person with chronic diseases? See, it is more advisable for the people who are having the chronic morbidities like heart problem, brain issues, lung problems, metabolic kidney problems, and cancer people. It will give more protection and they will be protected more compared to the normal people. Are the safe for the children? Of late, it is not been advised for the kids older than 18 years. If the research is going on, in few countries like US and Canada, they have got approval on emergency basis. But in India, it is advised only after 18 years. So what is how the community will be protected if I take a vaccine or our family members? See, I will show in a pictorial way. The red people are the infected one. The other people are the susceptible people. So if you take a vaccine, if they get an infection, they will have the herd immunity in the community. So the red person will be in the center. Other yellow people are the infected or immune people or vaccinated people. The other susceptible people will be protected from the infected people. So this is called herd immunity, remember. So more number of vaccinated people are there means the infection rate to the susceptible people will come down. This is the logic behind the giving protection to the third wave for the children, remember. And then so do it for friends, family, and other co-workers. Then I'm going to repeat the same thing. Protect yourself and loved ones from the corona. Wash your hands regularly. Cover your mouth and nose while sneezing and coughing. avoid close contact. If you have any fever, cough, and difficulty, don't treat yourself. Don't try to isolate yourself, and don't take medication by yourself. Taking advice from your colleagues. Consult your doctor immediately. So avoid 3Cs, crowded places, close contact setting, and confined and closed spaces. See, I'm being involved in the educating in the media, in the newspapers or in the TV. So we have been involved in the publishing the articles recently in the Inadu and in the Hindu also. See, for the kids who have been in the vaccination zone, means in the vaccinate, they require vaccination, regular vaccination should be done. Because of this COVID pandemic, the vaccination has reduced it to 20%. But consult your doctor and get it vaccinated for kids. So if you are worried about the minor infections, take a video consultation and teleconsultation. Don't go for regular small issues. But vaccination is mandatory for all kids. So wait for your turn or sit in the cars and go and get vaccinated for your kids and come immediately. Stay home. Thank you.
డాక్టర్ గారు,
చెప్పండి సార్.
చిల్డ్రన్స్ కి కొత్తగా వస్తున్నటువంటి వైరస్ లో థర్డ్ వేవ్ లో చిల్డ్రన్స్ కి బాగా ఎఫెక్ట్ అవుతుందని చెప్తున్నారు. దానివల్ల వాళ్ళు హోమ్ ఐసోలేషన్ లో ఉండొచ్చా పిల్లలు, లేదంటే వాళ్ళు పేరెంట్స్ దగ్గర కాకుండా వేరే ఉండాలా? రెండు ఈ వేవ్స్ లో ఎలా ఉంటుంది? ఆల్రెడీ ఇండియాలో కూడా స్టార్ట్ అయింది ఇది. ఈ మ్యూటేషన్స్ ఎంతవరకు వెళ్తుంది? ఆ సిమ్టమ్స్ ఎలాగుంటాయి కొత్తగానే? పాత సిమ్టమ్స్ అయినా లేదా కొత్త సిమ్టమ్స్ ఏమైనా వస్తాయా?
మంచి క్వశ్చన్ అడిగారు సార్. ఇక్కడ ఫస్ట్ వేవ్ లో ఏంటంటే మెయిన్ గా పెద్దవాళ్ళు అంటే 45-60 ఉండేవాళ్ళు ఎక్కువ ఎఫెక్ట్ అయిపోయారు చాలా వరకు. తర్వాత మిడిల్ ఏజ్ గ్రూప్ వాళ్ళు యంగ్స్టర్స్ తప్పించుకున్నారు. సెకండ్ ఏజ్ దీంట్లో వచ్చేసరికి మిడిల్ ఏజ్ యంగ్స్టర్స్ కూడా ఎఫెక్ట్ అయిపోయారు. మిగిలిపోయిన వాళ్ళు ఎవరంటే పిల్లలు మాత్రమే. కాబట్టి వాళ్ళలో ఇన్ఫెక్షన్ థర్డ్ వేవ్ వస్తుంది అనేది ఒక అజంప్షన్ అంటే ఊహ అన్నమాట. సో ఇప్పుడు దాకా ఎందుకు రాలేదు, ఇకపైన ఎందుకు వస్తుంది అంటే వైరస్ ఒక యాంటీజెన్సిటీ మార్చుకోవటం వల్ల, లేకపోతే మిగిలిన ససెప్టబుల్ గ్రూప్ వీళ్ళే కాబట్టి వీళ్ళకి వస్తుందా కంపేర్ టు అదర్ గ్రూప్. ఎందుకంటే ఆల్మోస్ట్ అందరికి కూడా ఇన్ఫెక్షన్ వచ్చింది కాబట్టి. సో ఫస్ట్ వీళ్ళని హోమ్ ఐసోలేషన్ అంటున్నారు. మెయిన్ మీకు దాంట్లో చెప్పేటప్పుడు చెప్పాను ఏంటంటే వీళ్ళకి యాంజియోటెన్సిన్ రిసెప్టార్ 2 అనే లెవెల్స్ అనేవి రిసెప్టార్స్ కొంచెం తక్కువగా ఉండటం జరుగుతుంది. అదే ప్రపంచంలో అన్ని కోణాల్లో కూడా అధ్యయనం చేయడం జరిగింది. దానివల్ల ఇప్పుడు వీళ్ళకి వాళ్ళు తప్పించుకోవడం జరుగుతూ వచ్చింది పిల్లలకి. కానీ పిల్లల్లో వచ్చినా కూడా తీవ్రత తక్కువగానే ఉంటుంది, కానీ ఇన్ఫెక్షన్ ఎక్కువగానే ఉంది. ఎంత ఇన్ఫెక్షన్ వచ్చిన పిల్లలు ఎక్కువగా ఉన్నా కూడా వాళ్ళలో తీవ్రత తక్కువగా ఉండదు. వీటన్నిటిని మనం తప్పించుకోవాలంటే మనము మన చుట్టుపక్కల ఉండే వాళ్ళందరూ ఇన్ఫెక్షన్ అంటే పిల్లలకి కాంటాక్ట్ లో వచ్చే వాళ్ళందరూ కూడా వ్యాక్సిన్ వేసేసుకున్నారు అనుకోండి సపోజ్. నెక్స్ట్ పిల్లలు ఈ థర్డ్ వేవ్ వచ్చేదాకా ఎవరితో కూడా బయట వాళ్ళతో కాంటాక్ట్ తెలియని వాళ్ళతో కాంటాక్ట్ లేని వాళ్ళతో అంటే పరిచయం లేని వాళ్ళతో కాంటాక్ట్ లేకుండా చేసామనుకోండి, దట్ ఈస్ కాల్డ్ హర్డ్ ఇమ్యూనిటీ అంటాం. సో వాళ్ళు ప్రొటెక్ట్ అయిపోతారు, ఇన్ఫెక్షన్ వాళ్ళ దగ్గరికి వచ్చేదానికి అవకాశం ఉండదు. బట్ అది వ్యాక్సినేషన్ వేసుకోకపోయినా పరిచయస్తులు లేని వాళ్ళ దగ్గర కూడా అందరిది కూడా మనం పిల్లల్ని పంపించిన, గ్రూప్స్ లో ఆడిచ్చిన, ఓపెన్ క్రౌడెడ్ దాంట్లో ఉంచిన ఎవరికైనా ఇన్ఫెక్షన్ వస్తే మాత్రం వీళ్ళకి వచ్చేదానికి అవకాశం ఉంటుంది. లక్షణాలు మాత్రం అవే ఉంటాయి మోర్ ఆర్ లెస్.
ఓకే సార్.
Good evening, sir.
Good evening sir. చెప్పండి
Sir, are there any guidelines for testing the neonates for the COVID? Can you throw some light on that one?
Raghu, I have mentioned that one, what is called as for testing, how to do when the mother is positive or symptomatic, you have to do the test around 24 to 48 hours immediately after birth. And second, if it is negative, we have to do around 6 days. Then if it is negative, then you can take it granted that they didn't get the infection in the perinatal period. So any sort of signs after discharge, that is mainly because of the attendants or they got the infection from the caregivers, from healthcare people. Once you find any sort of symptoms, you have to do the test immediately, and you have to categorize the child which he belongs. There is a mild, moderate, and severe. If it is a newborn, you have to categorize the mild, early onset and late onset, and depending upon the clinical condition, you have to take a call for treatment.
So what is more accurate, the oral or the nasopharyngeal swab?
Sometimes you may not get the nasal, so better to have the oral.
Okay, sir. Thank you.
Yeah, respected sir. Very nice of you. You have enlightened very much. Sir, you have told intrauterine transmission, transplacental transmission intrauterine, but there it was given inhalation and ingestion. Is it possible intrauterine?
It is published in recent articles by the Neo Reviews, sir, in this year, in 2021.
Is it? I want to share my experience also. Just very recently, we have seen a child just 1 day old with abdominal distension and bilious vomiting. And that child was treated as gut gangrene and got operated by the pediatric surgeon. The entire small gut was resected and the child was saved. Later, it was proved the child is having COVID infection. Have you seen any this type of cases, sir? Neonatal COVID infections?
No, it is maybe one thing, maybe MIS-C-N or the COVID infection, sir. Because in the day one itself, there is a rare chances of getting the transmission from the mother or caregiver. So it could be mainly of intrauterine transmission only. Second thing, it could be a missing mother. The mother is getting, if the mother had any sort of infection during the pregnancy and she develops antibodies and it's transferred to the placenta into the babies, and they may have the flare up of the immune response. And one of the things is the gastrointestinal. We have seen the cases with the myocardial compromise, sir, and along with the breathing difficulty and PPHN in our locality.
Okay, thank you, sir. Thank you very much.
First of all, I want to commend you. You have given such a beautiful talk, Dr. Satish Kumar. It's very thorough, and most importantly, I'm impressed with the facts, because there is so much misinformation, so much obsolete information. You're so good the way you presented all the facts, very intellectually and very factually. So I truly appreciate it. I'm Ganapati from Chicago. I'm very interested in this COVID stuff too. I'm a primary care doctor. So you did give such a good talk. I have a couple of questions for you. One is, I know in adults, we're using CT scans only in critically ill people. We don't want to overdo any CAT scans and everything. But in children, you mentioned about the chest X-ray. How sensitive and specific is chest X-ray for the children? Do you ever use CT in children when they're critically ill? Make sure they don't have any embolic phenomena like a pulmonary embolism type of a thing. If you could please comment on that.
Sir, see, CT, as you know, for the common people to understand, it is more or like equal to the 300 X-rays at being focused at a time, at a stretch. For a small babies, even though the radiation will be minimized as per the age and weight-wise recommendation, but still, if you have the clinically evident and moreover that you have the findings, the gross findings, usually when the baby is on ventilator and when the babies require such a, what you call it as critical care setup, with the clinical findings and with X-ray itself, usually it will be sufficient, first thing. Second thing is, you have asked about whenever you have done the CT. Sir, we have done the CT angio for n number of cases to rule out the pulmonary embolism, whatever may be amniotic fluid embolism, which is a rare phenomenon. But to find out any TAPVCs, suppose you have any diagnostic dilemma about the cardiac issues, then we have done many times. And sometimes you may find no clinical when you have inserted the arterial line, sometimes they land up in thrombosis. So that's the condition where you need to elaborate completely to see the renal arteries or renal veins or cardiac wise or lung wise. So we do for routine regularly if required, but not when the clinically evident for just for scoring or just for sake of completion, we don't do so.
I agree with you. That's definitely a good explanation, honestly. It makes a lot of sense too. I totally agree. And also, just two more quick things. What's the incidence of this myocarditis thing? We don't see that to be a major thing. But do you see a good number of myocarditis in infants and children at all?
Sir, in first wave, we didn't find much cases, but second wave, we could see of late few cases of missing. Depends upon the geography where we stay and depends upon the sort of infection they get and the immune response. Definitely, we may come with the data in next couple of weeks or maybe next coming months, maybe 1 or 2 months. So what sort of myocarditis they are getting and how severe it is and what sort of treatment they are requiring. At present, maybe 2 to 5% what we could see in the general population. Indian FOXI guidelines shows that they have clearly advised for the center to go for the vaccination even for the pregnant woman, even in the second and third trimester. They are the clear cut. They have recommended. In the view of the pandemic, the protection for the mother, that is the pregnant lady health and their personal health is also important apart from the pregnancy. The pregnancy is a very important thing that we accept, but the mother health or the lady health is per se is important. So first of all, they should get protected. And because the waves are coming within a span of 6 months to 9 months, so they need to have a vaccination that some forms as recommended for the center. At present, they are giving for the breastfeeding mothers. And in future, definitely, I think they are going to get the vaccinated for even for the pregnant mothers also. The remote chance of getting what he called as anomalies by transfer of the antibodies or whatever may be to the babies, that is not being analyzed or detailed studied in any part of the world. That's the reason even the topmost vaccine manufacturer companies, they're still giving complete assurance or guidance vaccination in pregnant women.
Yeah, the new wave in Western countries is absolutely we are prioritizing the pregnant women now. In fact, we want them to be front in the line, for the vaccination. Fortunately, we have surplus amount of vaccine now. Before, we were very proactively.
That will not be sufficient for India, sir.
I know. I understand. But the downside, we're looking at what's the downside of giving the vaccine versus the other way, because the time is in a sense, we don't really have time to wait and see while so many lives are wasted, especially now you're talking about the mother and the baby. Here you're talking about 2 people for 1 vaccine. So if you think about all these things, I understand the long-term safety needs to be checked and all those things. So far, how we understand these vaccines, none of them are live vaccines. And so what we understand so far is reasonably good enough to take that a little bit of a chance to vaccinate these moms to save 2 for 1. So that's the reason why American College of Obstetrician, so-called ACOG, is really pushing more and more. And I'm hoping that type of a strategy is going to be spread to the rest of the global, particularly countries like India and few other developing countries.
Sir, I would like to share one thing, sir. Compared to what you called as the last 2 years, last year, we could see less number of pregnancies and deliveries in India. The reason behind is, one is they went for abortion. Second thing is there is no marriages. Third thing is the IVFs are not being completely in the line for the for pregnancy aspects. So you could see very less number of deliveries and pregnancies from last 6 months, to be frank to say. We never seen such a low pregnancy delivery rates in India since we know. So the incidence, if you look at the other side of the spectrum, the incidence of the pregnancy wise and pregnancy complications wise could be the reason why we could not come across. But definitely what you said, definitely it is useful. It is a theoretical explanation what we get from right now. But in future, we'll get an evidence with a good sample size. They need vaccinated. They need to be vaccinated.
And also to cut down because first the question would be why children are getting the COVID. Obviously, most of the time it's from the parents because they're the one that come to exposure to these kids. So when we reach a point availability of the vaccines, I think they need to prioritize parents that has kids rather than parents don't have. I mean, the young people that don't have kids, they don't need to be prioritized as much as the young people that have kids, so that the infection doesn't go back and forth if you vaccinate these adults, young adults that has children, because they're the primary source for these children getting it, not only just the schools. And that's one thing. The second thing, in the Western countries, the new trend is, could we supply this vaccine to countries like India? Instead of vaccinating the children, first vaccinate all the adults, so maybe we'll cut down the spread. Of course, that's a noble thought. I hope they're going to follow some of that. Instead of just getting too eager to vaccinate the children, first make sure you vaccinate all the adults so you can cut down the transmission to the children. So these are the new trends. So we will see. The time is going to come.
In the slides, sir, how will the herd immunity will be effective in curtailing the infection to the other peoples, especially that have pictorial represent that have done that concept. That is immune people and non-immune people.
Yeah, very good.
Thank you.
Please, I'll give the rest of the people to ask. I'm sorry I took too much of your time, but I thoroughly enjoyed your talk.
We have two questions from Dr. Sitaram Raj Garu. One is, how to differentiate influenza and COVID?
That is, what do you call it as? No, the flu incubation period is 1 to 4 days. For COVID is 1 to 14 days. The peculiar things for the COVID infection will be the sore throat, fever with chills and rigors, severe myalgia, and the loss of smell and taste will be there in case of COVID. In case of the flu, the features will be the same, but not be so severe. And you can easily differentiate between the flu and COVID infection.
The second question is, which variant COVID infected in children is allowed vaccination? Which vaccine is better if allowed?
For children?
Yes, sir.
See, in the Western world, Pfizer is like got the permission to give the vaccine in US and Canada. And in Russian countries, they are doing the trials for Sputnik. In India, for what we got the information is the Covaxin is under the trials for vaccination in kids.
Thank you. So any more queries, sir? So
Can I make a just quick comment? One more thing, please.
Yes, sir.
Since I'm more into all the prevention and everything about the COVID.
Sure, sir.
You know, in India, even though we have surplus amount of water, but there are certain parts of the country, naturally, we don't have enough water for the hand washing and all those things. So just a regular hand washing, I know I mentioned this many times in my previous webinars. I may sound like I'm obsessed with this, but I'm not. Actually, I want to just emphasize this thing. Two things. One is hand washing with soap, not just pure hand washing. I know some people may say soap is a luxury, but it doesn't have to be any expensive soaps, just even a cheaper version of soap. Because in India, I grew up in India, even though I came 40 years ago to States. The amount of water they use to wash the hands is a very scanty amount. Water on the malani, that flushing is not enough on mata, flow is. On the malani, if you add soap and wash it thoroughly, that's one thing. The second thing is masks, cloth masks. How to use the masks అనేది అది చాలా మంది అది కొంచెం టఫ్ ప్రాబ్లం అండి. స్టిల్ మాస్క్ పెట్టుకోమంటున్నారు కానీ మాస్క్ ఎలా పెట్టుకోవాలో అనేది కూడా స్టిల్ అన్ఫార్చునేట్లీ the physicians have to take even more active role, leadership, and every now and then conduct some things like how to wear a mask type of a thing to educate the public. And that, I think, given what we have now, vaccination obviously is the #1 priority, but given the lack of supply, the next best thing is the mask, rather than, because we know it's transmitted through the droplets more than just a casual contact. So if we can actually push this issue of masks, how to properly wear the mask, and if somebody wants to do some public service, make them more cloth masks and donate, you can get more for the money the masks are. If somebody wants to do some public service or public donations, there is nothing at this time better than giving a mask to someone who can afford it, who cannot. This is just my view. I want you to please share your thoughts on that.
If you look at the, what do you call this, the kids who have been started walking or running, like 1.5-year kids or 2-year kids, it would be strange to see, putting the sanitizer still in the hands. They are enjoying in India. So, and mask also, we have different types of mask, like with the He-Man, Batman. They are also enjoying, and they are coming and showing, see my mask, this. But better, definitely there is improvement in the what you are suggesting, sir. But still, it has to continue and it has to be maintained properly. So definitely.
I agree. It's a work in progress, so we all have to pitch in as best as we can.
So one more question, sir, from Ms. Kavya. Are influenza vaccine helpful for the children under 10 years?
See, if it would have been like that, then would have been the what do you call it, the COVID infection from entire world. The people thought of MMR, BCG, flu vaccine because it belongs to or some sort of antibody response, protection or anything. But there is no clinical proven benefit.
Thank you, sir.
Thank you for giving an opportunity to interact in a unique for a platform.
Thank you. Thank you so much, sir. So you would like to tell anything to all, sir?
I want to compliment Dr. Satish Kumar one more time and Bharat also for conducting this thing.
Thank you.
I'm totally impressed with Dr. Satish Kumar's presentation. I think people in Visakhapatnam are lucky to have a doctor. I wish that type of knowledge and wisdom spreads across and more people could benefit from this. Dr. Satish Kumar gave such a fantastic presentation. It's so good. Sir, you should do this thing more often to other people and just spread your wisdom. Thank you very much.
Thank you, sir. Thank you.
Thank you so much for your support for the team.
Thank you. Thank you.
Thank you all.